I was asked to give a talk, and I had the liberty to choose what I talk, because not every time you have the liberty. So I decided to talk about the dilemma of social freezing. And the whole story started, I have a daughter who is 30 years, just turned 30 years old a few months ago. And she, for 5 years, was in America working for Google. And Google gave free lunch. They gave them free social freezing. So she would ask me every time, do I have to freeze? And I said, no, don't freeze. She was 25, and then 26, and then 27, 28, 29. I'm the father. So then I have to decide, and it's very difficult. So when she turned 30, she returned to Israel. And the next thing, my daughters, after 2 weeks, she told me, okay, Dad, we came to talk to you. You have to freeze her egg. So, you know, I had a chill in my back. And I said, okay, my daughter's telling me, and I am giving lectures, and they telling me when to freeze. And I said, when do I have to freeze her eggs? I tell you shortly, because then it would be the talk and not the story of my family. 3 months later, she was engaged with a friend, and they're seriously thinking of having a child and so on. And I hope she would not need freezing at any time soon. But that could have come. That could have happened. So with that, I would take you to this story that European continent, the population is really going down. Negative population growth in continuous problem facing Western world. Crude birth, for example, in Italy, is 8 in 1,000. This is very low. It never was so low. Italy contributed population to all the Western Hemisphere, including Australia and Northern Europe. So women are usually aware of the risk of delayed childbearing, but have false sense of security that IVF can solve everything. They hear, they read, and they think, okay, I do IVF whenever I need to do IVF. And they wait for Mr. Princess or Prince partner. But IVF has limited ability to overcome the age-related decrease in fertility. If you see to the left, you see that life expectancy is going up. I hope this shows, and I don't know if life expectancy is going up, but so also the marriage age that move forward 2 years every decade. So women marry later, and the problems start to accumulate and create over 30, so sooner or later, the problem hits in their face. Delayed marriage and birth, dramatic shrinkage of Western population, and there is also financial crisis and the Y generation, which is completely different. I don't know who is Y generation in this room, but he is different than our generation and the generation after us. So there are changes in the generation in what they want, what they perceive, what they want to do, what their plans. We as doctors, we cannot solve the financial problem of youngsters. It requires deep governmental help and involvement in what they want the next generation to be. And government today in all over Europe, but also all over the West, are so-and-so for doing this. We also cannot influence the change in society behavior, which is also due to prolongation of life. So there is a reasoning for that, but we cannot change it as doctors. But we think that we have a partial solution to help ease the population shrinkage, and this is social freezing. In the last decade, as an extension of the oncology-related fertility preservation and increasing efficacy of vitrification, this has fueled the imagination of patient and doctor to think that it is the solution for all young women. Some are calling over government, and also in my country, to support a large-scale fertility preservation of young women. It would not be a secret to say that those who are pushing the government to do it are gynecologists who are doing social freezing. It's the same people are pushing the government because it's a financial thing. And IVF is becoming more and more privatized, economic, and it's a financial issue, so you have to ask yourself always, where is the financial part and what is the real facts? Women are trapped between the hammer of social changes and the anvil of aging of ovaries, and are target for aggressive marketing of the procedures. In every country, you will start seeing, if you didn't see until now, pushing women. And as I told you, some companies are giving it as work benefit. So they tell these young women, listen, don't worry, freeze your egg, wait a few years, work for me as long as your brain is really young and creative, And then when you need, you'll have the egg waiting for you. But it is the right solution. So there's a company in America doing it. And the question is, what are the economical considerations? If it is cost effective to do it nationwide, to do it to all women, who should freeze? Why not pay upon usage? I mean, if I pay every time that I do social freezing and I'm not going to use it, why should I pay the whole price? So is it a trick here that we can change? And what is the indication? If not for all the population, is there an indication, some women that we can pick up and say, you need social freezing? Social freezing might give a sense of security to women and might delay pregnancy further, because if you have the eggs, so why bother, why run? And what is the cost of success? And how real is the security? I mean, I've frozen 15 eggs. Am I sure now to have a baby when I be 40? Not sure. What are the real facts? The age that you need to freeze, the number of eggs that you need, what is the cost of the procedure for the private or for the society? What do we convey them? What do we tell them? What do I have to tell my daughters who tells me, please freeze their eggs? And would she accept it? Maybe the train is already out, and women think that they should freeze, and whatever you tell them as a doctor would not help. It's the same like PGS. Everybody is doing PGS. Nobody's sure that PGS works or not, or is it safe or not, but they're doing PGS because they're doing PGS. And the question is, do you add or take of this security and stress of pressure of this woman? And then, if a woman freezes eggs, when does she tell her new boyfriend, look, I have eggs frozen away? Immediately the first date? It wouldn't work well. So do you wait 3 months? So he said, why didn't you tell me before? So this is a problem, I think. Let's first put the medical facts right. We as doctors, we have to know that the potential to freeze eggs for social freezing is there. It's a fantastic procedure. Let's look at the fact very quickly, very briefly. These are studies from the group of IVI, 486 cycles, various indication, freezing, and so on, a total of 100. So vitrification, and it's not the issue today for me to tell you, vitrification works. You have a 26% pregnancy rate, and so on and so forth. So employing 5.5 oocyte will almost give you a full success. And what is the meaning of these results? The meaning of these results, and the results that I'll show you later, is that, and it never changed from the beginning of IVF. I'm doing IVF almost, not 40 years, but 37, 36 years. Only 1 out of 4 to 5 oocyte will turn to be a baby. Only one in 4 or 5 oocyte. So if a woman wants safety to get a pregnancy, she needs 20 to 25 to 30 eggs, depends what age she is. So this is part of the meaning, but vitrification for itself works. And also the obstetrical and neonatal outcome and so on, they're surely there. The outcome is okay. There is no problem with these babies after vitrification. So we can vitrify oocyte, get a high yield, and get a high pregnancy rate. The perinatal outcome, there is no more non-haploidy, similar as fresh cycle. So all in all, whatever you compare, the results are good. But the question is, there is a conflict potential. Should we do this vitrification with indication or sell it as an insurance policy for everybody, for all? Social freezing is a procedure without clear indication. There is no indication. The combination of doctors selling insurance policy have a potential for conflict unless women are well aware and well informed of what they're getting, and we'll see it further on. Doctors now recognizing the financial power of insurance policy and business. This is a great business. You know, you freeze eggs, and in 20 years, you are not there. She's there with her eggs. Whatever happened, you are retired. Insurance is a very good business. You sell a future product which you hope to never need. In this case, you can't even promise full recovery of the loss. You cannot say, look, you lost a car, I'll give you a similar car. You lost a house, I'll give you a similar house. Not the same. You can only buy a ticket and stay in the game. So freezing your eggs is buying a ticket. Financially, it seems like every other insurance you buy during your life, except that here you pay the full price upfront for the services delivered years later, if at all. And this is the concept of usage. Are we going to use these eggs? How many of those women who freeze at 20 will use them at 40? Probably very few. So the question, when should we freeze? Social freezing, as the best expert in the world, is advocate and marketing the potential, and there is no competition. Those reproductive people are selling the idea, reproductive people are counseling, and nobody can compete with them with the knowledge and say, no, 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 this is not an insurance, not a good one, take another one. No, they know the facts. Success is better if you buy very early. So if you freeze at 20 or 25, sure, it's better than freezing at 35 or 40. But the earlier you do this, the chances of you using the egg are much smaller. And what's the indication? Let's look at a possible indication. We have a great tool, maybe practical solution for the Western world drop in fertility, and now we're looking for indication. But we have no specific plan of who to offer. What are the possible indications? Offer it to all women? I'm not sure, but you have to decide. Or even nationwide, like, you know, government, I'm not sure about that. To maximize the cost benefit, we need to freeze at early age, as I said, and use it at high percentage, which is contradicting. Most women will not need it, and not cost-benefit analysis was offered so far for overall policy. The concept is, an example of those who can benefit from this are those who will be poor responders. We all agree that if you take PCO patient, 20% of the population, they do not need early freezing at 25 or 30 or 32 or 30, because they would be fertile even at 40, 39 and 40. But other populations, like those who poor responders, we would say, yes, why not? This is a possibility. Other group is endometriosis. Endometriosis, you might be operated times and again. 1, 2, and the third operation, you are poor responders. We know that. So less and less gynecologists operate on cysts of endometriosis and touch them even before they have children, because it's the worst you can do. So here are two examples that are yes. There's another one, obvious for me at least, no, this is PCO. But can we diagnose these cases of poor responders? So I would like to dwell a little bit on poor responders. What do we have here? As you know, poor responders, I don't know if this works. Oh, yeah, it works, sorry. Yeah. As you know, the difference between poor responders and high responders is the number of oocytes in the ovary. So when you're young, they're loaded with the oocyte. Hormones are at normal range, and when you're older, they change. But poor responders, they get older sooner than the rest of the population. And if you look at the range of eggs in every year, for example, here is 25, there are women with only 10,000 eggs, while there are others with almost 1 million. And the mean is above 100. So there is tenfold between the population in the lower range and the medium, and another tenfold between the medium and the upper, and 100-fold between same two women at 25. So age cannot disclose the problem of who is poor responder. And also, if you look at it month by month, how much they can spend, how many follicles they do spend in a month time, in this window of a month. So you see the extreme goes from 10 follicles all over the month, so these are definitely poor responders, and 1,000. So they have 20, 30 eggs entering the cycle every day of the month. So these are high responders, these are poor responders, and this is the mean where they have, say, 100 for the whole month. And as you know, it's not only a question of quantity, but the quality goes bad as you advance with age. So we know poor responder is going to be everyone going to be poor responder with age, depending what age you pick it, but poor responders would do it faster. And there is another thing, is environmental, and today we must discuss environmental, because there are so many things in the environment that hits the sperm or the egg, that this is a second hit, sorry. a second hit that can even advance the age of being poor responders. So we know the risk factor for poor response: age, obesity, smoking, previous surgery, and so on. If it's previous surgery, then we know that you might be hit, so we go slowly with surgeries. But we don't have really a way of knowing who is going to be poor responders. So we have this test. Can we diagnose poor responders before it starts? There is this ovarian test that you know very well: FSH, AMH, follicular count, and age. I'll bring you to the summary. Ovarian reserve test utility in deciding a time of freezing. Markers cannot guide us to the risk of early aging or need for fertility preservation, and have 10 to 20% false positivity. The true ovarian reserve test is dynamic test response to stimulation. Our own experience is that when you have poor response, sometimes it immediately goes over to menopause. So conclusion, ovarian reserve test cannot guide us well to the time of freezing. So we have these to-be poor responders, but we only know that they are poor responders when they are poor responders. So this is too late. If I knew that she will be a poor responder, and that can go to even 20% of the population, something was mixed with my slide. Oh, something happened to my slide here. Just a minute. Okay, we'll see. We'll manage. Don't worry about that. And so, I'm missing a few slides. So if we would know that this patient is going to be poor responders, we would freeze her egg. I would be immediately pro nationwide plan, but we don't know. We cannot rely on the ovarian reserve test. We cannot rely on anamnesis, history taking, and so on. And when it started already, we'll see in a minute, this is already a poor time decision. It's not the best time. You do it because you have no choice, because the patient wants, and it's her money, and so on. Well, let's take this second indication. It's endometriosis. So endometriosis, if you know that you are going to operate the patient, I would freeze her egg first, because even the best operator might lose a big part, a big chunk of the ovary doing endometrioma. I personally did not operate in the last 10 years an endometrioma before I did IVF, because I think it's a big mistake. You should do the IVF, finish up with this, and then come back and do the endometrioma. And I know that people will debate this, but that's my idea. So about endometriosis, there is a very nice paper, recent paper by Edgardo Semiliana, that writes about literature is still speculative. No concrete data except for endometrioma surgery. So if you are about to do endometrioma surgery, then maybe you should. It can be beneficial in women with bilateral disease, repeated ovarian cyst, recurrent disease, and so on, young women, or family history that, so it's a small group out of this big bag of endometriosis. Assumption on endometriosis affecting fertility on long run, and if affecting it independent of surgery, this is arguable. Surely in unilateral disease, it's arguable because you always have the second ovary. And you can use oral contraceptive to prevent the cyst and improve prognosis and just wait until the day that you can do the IVF. So the question, should we freeze eggs in cases of endometriosis, is still hanging in the air. I think with more studies, maybe it will be positive. Maybe with more study, it will give you another route, a better way to go and try and start to, and have the disease under control. So this is for endometriosis. How many eggs do we need to freeze? And this is a big story here. You know, just to take you to the bottom line, it depends on the age. Because if you are, if you are young, you need less eggs. If you're older, we'll see it in the next slide. But anyway, you would need, to get 95% security, you need 40 eggs. And with 20 eggs, you get 80% security. So you're buying the insurance, you're doing 2, 3, 4 IVF cycle to freeze, and the only thing you're not sure is if you're going to get a baby 100%. It's not 100%. One woman will get 3 babies, and the other one will get nothing. So it's not for all sure. And remember the number, only 4 to 5% of all oocytes becomes a baby. And this didn't change for the last 40 years. At what age should we do it? What is the cost effectiveness of this? And this is, again, a nice study from the Ivy Group by Cobo. And you see that it depends. Women comes to you at 37, 38. Then they feel the clock is ticking very quick. But at that age, you need more than 30 eggs to freeze. So it means the eggs are less efficient in that egg. So we certainly do not want to be on the age that the woman comes to you, 37, 38. But we definitely do not want to be at 25, where the usage of this egg would be very low and the price will increase very much. The cost effectiveness will be low. This is from the internet. They take, they say, okay, give us your age, give us this, give us that. We can tell you how many eggs and at what age. But if you look at this, at the results here, then at the age of 44, 6 eggs will bring you to 10% pregnancy. At the age of 40, 5 eggs, 13%. At the age of 30, if you have 10 eggs, it's 28% security. So you need much more than that to be successful. That's not enough. You're selling here in insurance and you don't recover what you lost. So it is not surprising that there is also a wage against this. There is controversial and there are reservations to this, whether we should do it or not. This is early age, so Winston is a very smart guy, Lord Winston, but he at the beginning put it as expensive confidence trick. So he said, we are playing here. And in a way, all of us are playing here a little bit by what we promise. I must say that by the time he said that, the results became much better. So what are the advantage and disadvantage of social freezing? We know that freezing enough eggs at age 30 actually freezes the potential, but enough egg is not defined here. The advantages is obvious. You own genetics, you control of the destiny, low risk, sense of security, efficacy is good. Ethically, there is no problem. Religiously, there is no problem by the religion. No need for partner. The disadvantage is a limited window of opportunity. I think the opportunity is between 25 and 35, and to be honest, I think it's between 30 and 33, 34. Low usage and large scale, you need above 60% usage to make it cost effective in large scale. Otherwise, success is too low. So IVF has a limited ability to overcome the age. I think I lost some slides, but it doesn't matter. I think I made here the point. IVF has limited ability to overcome the age-related decrease in fertility because an increasing number of women are choosing to delay childbearing. Fertility preservation strategies are being applied to this group of healthy women. Studies supporting the effectiveness of this practice are missing. Economical considerations are somewhat conflicting. I'll show you at least 2 studies that have tried to answer this. This is a theoretical studies, fertility preservation for social indication, the cost-based decision analysis. Remember, it's a theoretical consideration based on results and prices that we know. So if you take a patient and you have no action at 25 and you come at age 40, do 6 cycles of IVF, you have 71% pregnancy rate. If you freeze outside at 25, you go 6 cycles, then use 6 cycles of induction of ovulation, then use the frozen eggs, you have 79% pregnancy rate. And this is another possibility that's freezing ovarian tissue, but I wouldn't think that this is something that people considering seriously, at least now. So the difference is not big, but the only thing is that when you do freezing, the cost of a baby is much, much higher if you go for the freezing possibility, but you have another 6%. Again, this is theoretical. So both freezing strategy didn't appear to be cost-effective compared to waiting strategy. And the conclusion was that fertility preservation is my conclusion, is aggressively offered and is a money generator and hence should be critically evaluated before offering it worldwide. And this is another study by a Dutch group where they use, again, 3 cycle, freeze at 35, treatment at age 40, they got 84 pregnancy rate. And then 3 natural cycle, trying at the age of 40, they tried to have a pregnancy. If they didn't succeed, then they moved on, and they got 52% pregnancy rate. And this is, again, 3 normal cycle, and then, this is with IVF, 64%. So you see here that the difference exists, but it's not huge. And their conclusion was that with 60% patient returning to get their frozen eggs, then it would cost them 19,000 euros for a birth, and this is a cost-effective. So if you have a usage which is lower, it would not be considered cost-effective. So the last slide that I'd like to share with you is to remind you that there is egg donation. And egg donation is a possibility. It can be offered at all ages. It's genetically different eggs, true. It's not your own eggs, but it's very efficacious. There is no risk. It gives you a sense of security, same sense of security. It is not that expensive because you stop when you succeeded. So it's not expensive as freezing 3, 4, 5 cycles. As you understand now, you need at least 3, 4, 5 cycles. Ethically and religions, there are reservations to that for some people, but the success is also very high, and it's not age dependent because the eggs are younger eggs. So let's summarize. 20 years ago, a new field of fertility preservation emerged. Social oocyte freezing by high efficacious technique of vitrification is an extension of the cancer-related preservation and the high efficacy of vitrification, and the overall drop in birth in the West, it can help this. Increase the chances to have our own genetic offspring. High pregnancy rate of normal perinatal outcome is expected with vitrification, and if it's done early, between 30 and 35, the chances are good. Social freezing is another solution for age-related decline in fertility and delay in marriage. The dilemma is no good indication. The other dilemma is marketing as an insurance to all. This is too expensive. And if done too early, results are better if the usage is high. So if it's done too early, it's good for the patient, but it's not good for the cost effectiveness, for the calculation of what we calculate as financially reasonable. Our role as doctor is to familiarize the fact of fertility drop sharply at 38. It should remain, social freezing in my belief should remain a personal decision based on realistic information. After giving all the information from the number of eggs, from the cost perspective, from the chances to conceive, and the fact that even if you get married at 38, you have a chance. The fact is that we cannot pick up those really with bad faith, these, the poor responders one, because when we freeze to them, it's already too late, and we need tens of eggs to get the success. Egg donation is another alternative that we should discuss. And as it is money generator, we really, physicians should be very cautious, at least on the long run, to know whether they just get all the population in and every woman who just knock on the door, they say, yes, we do it. So I would like to thank you very much, and with that, invite you also to COGI in Vienna at the end of November. Be happy to see many of you there.